Some of the greatest scientific findings have been discovered by accident. Research is a process of constant questions and tests, some of which may lead down a path more thought-provoking than the original plan. For Drs. Shoham Shoshin Hillel and Alex Gililis Hillel, their story started with a 2022 paper on how sleep deprivation affects decision-making. Alex is a sleep expert, while Shoham specializes in decision-making research. The couple decided to combine their interests to look at how empathy changes in doctors on the night shift. They noticed that these physicians were less likely to prescribe pain medication. But to make sure this bias was due to the lack of sleep, the team started looking for anything else that could cause the effect, like age, gender, or ethnicity.
We wanted to make sure that the night shift is the reason for what we see for the reduced likelihood to prescribe pain medication. But while we controlled for all these other factors, statistical regression, we found that, in fact, gender on its own also explains pain medication or the likelihood that the patient would receive pain medication.
So while sleep deprivation impacted decision-making, Alex and Shoham's research revealed that the patient's gender was a huge factor as well. However, this wasn't such a huge shock to the couple.
Our response was basically, well, isn't it kind of obvious? We know that women are being disregarded in many different contexts. We know that women are biased against in various conditions.
But then the duo took a step back and wondered if this idea had ever been scientifically proven, or was it just a myth continually echoed through society? It's a question that's been the focus of research over the last couple decades, but Shoham and Alex realized that none of these papers had reached a definitive conclusion.
There are lots of books saying, claiming, arguing that women are dismissed, their pain is not regarded as seriously as men's. A lot of people say that, a lot of women say that. But if you're trying to look at actual scientific evidence, if you want to see something that will actually convince you that this is not just what people say, it's actually out there, then you have to find some convincing proof. You have to control for everything else.
And they also had to find a common ground between men and women for pain. You can't compare the agony of labor or endometriosis because there's no direct equivalent in men. So Alex and Shoham needed to find a condition that was common in both sexes.
And beyond being common, we wanted not to be a specific course of treatment, to sort of leave room for bias or for physician deliberation. And that's how we ended up with looking at a specific setting, which is a very common setting for pain, which is the emergency medicine, emergency rooms. And we looked at complaints that we describe them as vague or without a specific identifiable source. Again, with a thought in mind that we want something that is not guideline strict, or you don't have a completely structured pain plan, which would leave some room for bias by the treating physicians.
The best fit for these requirements turned out to be looking at headaches and backaches, which are some of the most common pain complaints in the ER. They reviewed around 20,000 instances of patients going to the emergency room with a pain complaint and then being discharged the same day. These data points were taken from both Israel and America, so the team could see if location impacted the results at all. After looking at various cases in both locations, the research published in the Proceedings of the National Academy of Sciences revealed that females received less medication than men for the same pain complaints.
So for this same level of pain, reported pain, for the same headache or the same backache, the likelihood that a woman, that's what we find, the likelihood that she will get any kind of pain medication, even some Advil, is lower than for the men.
To make sure that the issue wasn't that men were being overprescribed, the research compared the data to the World Health Organization's guidelines for pain medication. Even after controlling for various factors, the researchers were shocked at how prevalent the disparity was.
It comes up any way you test or split the data every year in every center separately, across all ages, in each age category, young women versus young men, older women, older men, religious women, whatever combination you choose.
And importantly, for every pain severity. So women get less pain medication than men. Even for pain 9 out of 10, which would be described as almost the worst pain you ever experienced in your life.
This was the first of 3 areas the researchers studied. The pain medications were divided into opiates and non-steroidal anti-inflammatory drugs. Perhaps unsurprisingly, the disparity was found in both groups.
You cannot argue that women are getting less opioids because of some paternalistic desire to protect them from opioid epidemic, for example, because NSAIDs or Tylenol would not be included in such an explanation. They're getting across the board less painkillers, whether it's opioids or analgesics. That was kind of the basic effect.
And we were quite shocked, to be honest, at how large the effect was, how consistent. It's just really hard to make it go away. You see it every way.
We tried to adjust for any variable. We couldn't make it disappear.
Yeah. And the reviewers of the paper tried their best as well to add all kinds of controls to check this, to check that. Are you chronic pain, non-chronic pain, internal AD, surgical AD, wherever you look, it's still there.
Aside from prescriptions, there were 2 other areas of research that are related to pain management, but not directly associated with medications. One is the pain score. That's often written down by a nurse while they're recording other vitals like blood pressure.
For the same pain complaints, women got their pain scores recorded less often than men.
About 10% less, which is quite significant. So just writing down, typing in this number that the person tells you happens less when you're a woman. People don't, and we don't know if they were not asked about their pain
or just not,
or no one cared to write it down, but this way or the other, it was not there.
The final part of the research that affects pain management is emergency room wait times. Sadly, the results are just as disappointing.
So it appears that women wait about half an hour longer. If the average stays about 4 hours for this type of complaint, in our systems, women wait 4.5 on average. Again, adjusted for any condition you might think of. So their severity of complaint was the same. The age of the person was the same.
They even accounted for people who wouldn't be given painkillers, such as pregnant women. Still, the data shows a 30-minute longer wait time for female patients. One difficult factor that can't be discerned from data points is the conversations patients are having with their providers. Maybe men are presenting their situation differently or are more demanding. To try to control for that unknown, Shoham and Alex ran an experiment. They sent out a written medical scenario to health professionals in Missouri and got responses back from nurses and physicians. There were 2 variations of the prompt, but the only change was the patient's gender. One was Mr. Jones and the other was Miss Jones. Everything else was exactly the same, with the fictional patient reporting a terrible headache that they rated a 9 out of 10 on the pain scale.
And we asked the healthcare professional to rate the pain that they think this patient is suffering from. So they saw the same complaint. There was nothing in the behavior of the patient that was different because it was all written down. And the healthcare professionals rated the pain as lower, as less intense when it was reported by Miss Jones rather than Mr. Jones.
Some of them actually wrote in the comments we left for the study. We didn't quantify it, so we don't know the actual magnitude of the effect, but some of them did write, and it feels like more for the female scenario. We think she's exaggerating. She couldn't be feeling pain 9 out of 10. She doesn't have anything objective on her exam. So it was kind of saying to us that at least some of the bias comes from the professional sides, not from the patient, where women are considered hysterical and exaggerating.
Unfortunately, the seemingly simple solution of hiring more female health professionals won't make a difference in how women are treated.
So going back to the stereotypes, we know that females also stereotype females. We know that in hiring decisions, female managers also discriminate against female candidates, just like male managers do. And that's because of some stereotype they have about the candidates, thinking that the males are better than the females. So if the stereotype explanation is true, we should find exactly the same discrimination here by female doctors and by male doctors. Because if everybody thinks that female patients are exaggerating, hysterical, so should female doctors. They should think the same and therefore provide less medication, pain medication for female patients. And this is
this turned out to be true. female doctors discriminate or provide less analgesics to the same degree as male physicians.
Even though the answer isn't to hire more women, there are some methods that Alex and Shoham believe could help reduce this glaring disparity. The couple thinks that incorporating nudges into the healthcare systems could be an effective approach. A simple reminder that pops up on the laptop screen could help physicians overcome any subconscious prejudices.
So, hey, did you see that this patient reported a 9 out of 10 and you haven't prescribed any pain medication yet? Would you like to prescribe any? And the final decision, as a nudge, would still be the doctor's decision. We're not forcing them to prescribe anything. It's not automated. Maybe there's a reason not to, but the reminder itself, we think, might help de-bias this sex bias and perhaps make it more salient to doctors that their prescription is not in line with the pain report by the patient.
Shoham and Alex are currently setting up this type of alert system in a Pennsylvania hospital, and soon they'll be able to see real data of how effective this integration is. You can find more information about Dr. Shoham Shoshin Hillel, Alex Gililis Hillel, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.